Thank you, Madam Chair, and thanks for all your efforts to achieve bipartisan bills today. The committee is marking up 13 bills, all of which have bipartisan support, and we'll begin by considering a few bills to strengthen our public health programs. I'm pleased we're advancing legislation championed by Representative Boyle, who will allow HHS to evaluate this bill will allow HHS, I should say, to evaluate existing research on women and underserved populations and correlations to lung cancer. And this bill is important because it allows scientists and policymakers to identify opportunities to accelerate research in this area and develop a public awareness campaign on lung cancer screening to better reach underserved populations. I'm also pleased we're advancing the Shine for Autumn Act, led by Representative Castor on the Democratic side. This legislation was spearheaded by Debbie Haynes, who I understand was originally from my district, and the purpose is to give meaning and purpose to the tragic loss of her daughter, Autumn, and it's going to put a needed focus on preventing stillbirths through enhanced data collection, research, education, and awareness. This bill is the beginning of a long-term solution to reducing stillbirth rates that tragically affect many families. Next, we'll consider a bill to strengthen the Medicaid program. I'm pleased we'll consider H.R. 4758, the Accelerating Kids Access to Care Act. And this bipartisan bill streamlines the process for out-of-state pediatric providers to enroll in Medicaid so that children who need specialized treatment outside of their home state can access that care in a timely manner. And I want to thank Representative Trahan for her leadership on this bill, and I hope that it'll bring some peace of mind to the families of children who face unnecessary and devastating delays in getting the care they need. We'll also consider a bipartisan amendment to the Accelerating Kids Access to Care Act that includes a prohibition on spread pricing in Medicaid. Spread pricing occurs when pharmacy benefit managers keep a portion of the amount paid to them for prescription drugs instead of passing those payments on to pharmacies. And this practice unnecessarily drives up pharmaceutical spending. Banning spread pricing in Medicaid was part of the bipartisan Lower Cost, More Transparency Act passed by the House in December, and I hope that it can soon become law. I'm also pleased that we'll consider 4 bipartisan Medicaid program integrity bills, including H.R. 8111, which will require states to collect beneficiary address information from Medicaid managed care plans. And this simple policy will help state Medicaid agencies stay in better contact with beneficiaries to renew their eligibility, while ensuring that beneficiaries who no longer live in the state do not remain enrolled in the program. Then there's H.R. 8084, the Live Beneficiaries Act, that requires states to more regularly check Social Security Administration death records, ensuring Medicaid is not making monthly payments to managed care plans for beneficiaries who have passed away. Now, turning to Medicare, I'm glad we found a bipartisan path forward on H.R. 5526. Congress enacted the Physician Self-Referral Law, also known as the Stark Law, to ensure that physician financial considerations do not influence patient care. Under the Stark Law, physicians are prohibited from making referrals to entities in which the physician has a financial stake. Medicare beneficiaries deserve the independent judgment of their physicians and access to treatment that is medically appropriate and necessary for them. And the Stark Law is critical in ensuring that financial arrangements do not distort physicians' decision-making or raise health care costs. And while I have strong concerns with weakening the Stark Law, I believe there are limited instances in which it may be necessary for a caregiver or a family member to pick up prescription drugs for patients or for prescription drugs to be mailed, which is currently prohibited under the Stark Law. I believe this narrow Stark exception would help patients receive necessary medications but still protect Medicare beneficiaries by ensuring that provider decisions are made on the basis of clinical criteria. So I'm pleased we're able to include additional guardrails to ensure that patients have access to treatment and care that is based on medical necessity. I'm concerned that some technical assistance provided by CMS has not yet been incorporated, but I understand that Chair Rogers is committed to work with me to address the agency's feedback before the bill is considered on the House floor. So I'd like to thank the Chair, again, for this truly bipartisan process and for only moving forward on bills with bipartisan support today. There are other health priorities, including telehealth, that just were not ready for today, but I look forward to continuing to work together on these outstanding bills. And with that, I yield back, Madam Chair, the balance of